Good afternoon or good morning, depending on where you're joining us from. And thanks for joining us for our closing live session of the LSX World Congress in the Biotech Leaders track. And indeed, for the event as a whole this year. It's, I think, for the session focus of today on capital deployment and commercialization strategy and some of the panels and sessions that we've had before. This report that's about to be presented has obviously got a US focus, but it is an extremely sort of pertinent way to round off some of the discussions that we've been having over the last day or so. I'm delighted to be hosting today as our speaker, Andrei Ostrovsky, former CMO of Chief Medical Officer for the US Medicaid program and managing partner with Social Innovation Ventures. And the presentation title and report title, indeed, Challenges and Technology Solutions for Dual Eligible Populations in the US. So please do keep your questions and comments coming throughout the presentation in the chat and Q&A function on the right-hand side, as you have been all day. And we'll get to as many of those as we can towards the end, or indeed throughout the presentation if feasible. But for now, I'd like to hand you over to Andrei. Andrei, stage is yours.
Perfect. Thank you so much, Josh. Really appreciate you having me. And I hope everyone has had a good conference. I'm going to try to keep this precise and very happy to go into detail. If you have any questions, comments, please feel free to submit them and I'll try to tackle them as we go. So for the next 30 minutes, what are we going to talk about? Challenges and technology solutions for dual eligible populations. Let me give you just a little overview of the study that we did. By the way, this study was published pretty recently, back in November of 2020. The study was funded by the California Healthcare Foundation, and it was done with a couple of my mentees, which did an excellent job. The actual study is referenced there down at the bottom in the source. The purpose of the study was fivefold. First, it was meant to describe the context of dual eligible participants in California, although we did have a broader aperture to incorporate also the duals across the United States. The second purpose of the study was to characterize the barriers to address duals' health needs, as identified both in a literature review as well as interviews with experts and key stakeholders in the space. We also wanted to characterize new technologies that were applicable to dual eligible beneficiaries. We also wanted to apply this review of existing technologies to the gaps that we identified in the literature. So we tried to stage gate this. What's the literature say? What do experts say? And then what is our review of the technology ecosystem? And finally, my team and I proposed some future directions that technology investment could take to better serve duals and the supply chain that serves those duals. And so today I'll be providing you with some of the findings from our research. More of the details are available in the actual report. I'm also happy to answer any questions that folks can't necessarily find online or in the report. With that, let me share a little context on who are duals. So duals are a construct that's pretty unique to the United States in terms of how they're defined, but the people themselves are ubiquitous across the world. In the United States, there's a Medicare program and a Medicaid program. The Medicare program is a program that is a public insurance program for mostly people that are 65 and older, but also there are other ways to become eligible, including long-term disability, as well as people with end-stage renal disease. The Medicaid program is a public insurance that is meant to insure folks that are low income, as well as people that have functional compromise. And sometimes folks that are on Medicaid for 2 years or more then become eligible for Medicare by virtue of their functional status. And so the folks that are dually eligible for Medicare and Medicaid are both have Medicare and Medicaid insurance. And I'm happy to get into those nuances of which part of care does Medicare cover, Medicaid cover. The bottom line is this tends to be a sicker population, lower socioeconomic status population, and thus they are much more highly predisposed to morbidity and mortality than the general population. Some specific statistics relevant to duals now that we have a little bit of context. 60% of duals have multiple chronic health problems. 41% have at least one mental health diagnosis. Roughly half of duals are eligible for Medicare by virtue of disability. The other half are eligible because they're 65 or older. So there's a very high disease burden around functional compromise in this population. 20% of Medicare beneficiaries, 1 in 5 of all Medicare beneficiaries are dually eligible, and they make up 33% of total healthcare costs. So there's a little bit of that Pareto rule going on. While 15% of Medicaid beneficiaries are dually eligible, and they make up 34% of the total cost. So even higher proportion of Medicaid bennies that are duals than Medicare bennies. Duals are 4 times more likely to get COVID-19 as non-duals and much more likely to be hospitalized. Mortality rates are also significantly higher. And fortunately, we have a lot of reason to be optimistic around COVID-19. Nevertheless, this is a population that remains and will remain highly compromised, especially those folks that are homebound and are stuck and perhaps are not able to get out there and get vaccinated. When we did our research, the literature review identified 4 different domains where there are gaps that are technology amenable gaps experienced by duals themselves or the supply chain serving them. In other words, providers or payers reimbursing care for duals. Those gaps include care coordination gaps, data collection and sharing gaps, culturally sensitive enrollment and engagement challenges, and challenges around home and community-based services. And I'll dig into some of the technology nuances there, as well as some of the underlying data. Now, how do we go about actually conducting this technology assessment? The details of this methodology are in the report, but also in the source, I provided a link to the inventory of the 84 candidate companies that were reviewed and included in this report. This is not an exhaustive list, but it is a pretty good glimpse, or at least a cross-section, into the technology ecosystem serving these patient populations. When we were reviewing the 84 candidate companies, we looked at them through the lens of these 5 variables. The first lens was funding, level of funding. In other words, we wanted to look at companies that had at least Series A level of funding. So pretty early stage, but enough traction that they were able to secure institutional funding. But we constrained the upper limit of funding to companies that had Series C level of funding. In other words, companies with Series D level of funding or higher were, for the most part, excluded from the analysis. That includes companies that have been acquired or had some other M&A type of activity, and companies that have gone public. So we're really looking at companies with Series A through Series C funding. The next variable we looked at was the company actually serving duals. The way that we assessed that was by either company self-report or reviewing the collateral that the companies provided on their website. We did have a 2-researcher validation approach where one researcher would review and then a second researcher would independently review when there was a discrepancy. There was a third researcher that would kind of reconcile the differences. And we looked at the end user that was being served as a primary as well as a secondary customer segment. And that way we could have a little bit of granularity there. The third variable we looked at was the level of evidence. This one was a pretty interesting one, and I'll get into why that's the case in a few slides. The categories we looked at for level of evidence included no evidence. Then we looked at gray literature, including things like white papers. We then looked at whether a solution was based on existing evidence-based practice. We then looked at solutions that had a single peer-reviewed study, excluding randomized controlled trials, then multiple peer-reviewed studies, also excluding randomized controlled trials, and then at least one randomized controlled trial. And the rationale for this sequencing is that that essentially is on the spectrum of least to greatest level of rigor. The next variable was the end user. And for the end user, we had three subcategories. We had the primary, secondary, and tertiary end user. And then there were, within each end user type, there was 6 nominal categories. In other words, the solution could be selling to the consumer directly. The solution could be selling to a health plan, a medical provider, a non-medical provider, like a home care worker, for example, or a family caregiver, a pharmacy benefit manager, PBM, and an employer. Under the variable for financial customer, we had 3 subcategories, again, primary, secondary, tertiary, and we wanted to account for the fact that a company might be selling to multiple financial customers. So this is the actual check signer for a solution. And the different financial customer types included 11 categories. Those were consumer, Medicare Advantage plan, for example, a dual special needs plan. So for those that are not here stateside, that's a nuanced type of Medicare Advantage plan, which I'm happy to elaborate in the Q&A. Medicaid managed care organizations, for example, managed long-term supports and services plans, individual or exchange plans, commercial plans, so employer-sponsored insurance. Medical providers were another type of financial customer subcategory. PBMs, as mentioned before, employers, non-medical providers, a new one here, which is state government, and then the federal government. And so an important distinction between end user and financial customer is that the end user might be the entity that's actually interacting with a piece of software or a service. The financial customer is the entity that's actually signing a check. Sometimes it's the same, often it is not. And the final variable we looked at was technology type. We again put it through the lens of primary, secondary, tertiary, and the subcomponents there included 8 categories. Those included business process as a service, things like revenue cycle management, consumer, digital, provider or enterprise, tech-enabled services, telehealth, and other. There were 49 additional subcategories within those broader 8 categories. And I can elaborate on those if folks have questions, but we got pretty detailed. Again, the link to at least a high-level overview of the 84 candidate companies are there in the source. So let's jump into some of the results. First, looking through the lens of end users, what our data showed is that 64.3% of the companies that we surveyed were targeting the consumer as the end user. About 1 in 4 were targeting a medical provider. Just shy of 10% were targeting a health plan. And just under 4% were targeting a non-medical provider. There's a lot to dissect here. And one of the findings we thought was very interesting is that many of the consumers that are dually eligible, by virtue of the fact that they're such low socioeconomic status, often do not have steady access to high quality cellular data and Wi-Fi for that matter. And so there may be a disconnect in the sense that the majority of end users of these solutions are consumers, but that seems to be inconsistent with the fact that many of these consumers are homeless. And many, not majority, many of these consumers have pretty significant, not just housing insecurity, but insecurity around data access. So that was an important gap. Another important gap we noted was that less than 4% of the target end users were non-medical providers. Given the overwhelming amount of functional compromise that exists in this patient population, there is a huge role that non-medical providers play. And those folks include home care workers, home health aides, community health workers, home delivered meal providers, and frankly, most of the interaction that happens between a care team and a dually eligible individual is with a non-medical provider. And yet only 3.6% of these solutions are targeting that end user. And we observed that the disconnect between the target end user and the access to the technology is a very important market failure, as well as the disconnect between the non-medical providers. The next set of data, in the next set of data, we look at the financial customer. And this is the actual check signer. What we learned is that the most common financial customer was a medical provider. The second most common was the consumer themselves. And then individual health plans were subsequently the next three most common, but in aggregate, health plans accounted for about 45% of the target financial customer. Employers very rarely were targeted at 2.4%, non-medical providers only 2.4% as well, and then state government, most notably state Medicaid programs, were only targeted 3.6% of the time. One of the most interesting things here is that with the consumer being targeted more than one out of every five solutions that were targeting a financial customer that happened to be the consumer, the disconnect there is that almost all of these consumers have an inability to spend discretionary dollars on anything other than food and shelter. And so the payment parity issue here demonstrates a disconnect in that the consumers have limited purchasing power, and yet the technology providers, the solution providers, are targeting or selling something to a consumer, which might suggest that the innovators and or the investors just don't fully understand the consumer for whom they're trying to create value. And that's an important takeaway for investors and also for entrepreneurs that are serving the space. One quick note about payers, that from my own experience seems to make a lot of sense, that tends to be the target of solutions in terms of the financial customer. What was a little bit surprising there is that commercial plans appear to be targeted pretty frequently, and commercial plans, employer-sponsored insurance, really has very little to do with dually eligible beneficiaries, because if by definition they're dually eligible, they're not having their care reimbursed through employer-sponsored insurance. And so this suggests that companies that are marketing themselves as serving duals appear to actually just be serving an employer-sponsored population and just saying that they're serving everyone, when in fact they're not particularly focusing on duals. Next set of data is around evidence, and I would say this is one of the most important take-home points of our research. So what we found here is that over 41% of the solutions had absolutely no evidence to reaffirm the marketing claims that they were making. The next level of rigor, if you will, is down at the gray literature, and there 23.8% of the companies had some kind of case study or white paper. Now that's not peer reviewed, that essentially is equivalent to just marketing materials, but at least there was an effort to represent some kind of outcomes. 1/4 of the solutions we reviewed were based on some kind of rigorous evidence-based practice. Now that doesn't necessarily mean they were implementing with high fidelity to the evidence-based practice, but at least they were trying to build upon evidence-based practice. And then we start getting into the more rigorous and serious solutions. And so the companies that had at least a single peer-reviewed study in that pink, there was only 2.4% of the companies we analyzed, only 1.2%, basically one company of the 84 that had multiple peer-reviewed studies. And then there were only a handful of companies that had at least one randomized controlled trial. And so when we're operating in a space that is predicated on a foundation of evidence-based practice, we're finding that the vast majority, over 90% of companies, have not tested their product or service in any kind of peer-reviewed setting. And interestingly, 7 years ago, I did some research with my colleagues from the Institute for Healthcare Improvement. We did a very similar analysis. It wasn't constrained to duals. It was focused on digital health more broadly. And we found essentially identical findings. We noted that the vast majority of companies we evaluated only had emerging evidence, which is really a polite way of saying they had no evidence. We had 12 of the, I believe, 87 companies at the time that were evidence informed, and only 20 that were evidence based. And so there was, when we ran the analyses trying to correlate level of evidence with the level of investment, there was not even a close resemblance to a correlation there. So that's an unfortunate gap that really needs to be filled. And so now jumping into, oh, let me just see here. We've got a question. Let me answer this question before I move on. Question reads, you mentioned many companies attempting to create these technologies don't understand the purchasing power problem. What do you think they need to do about that or consider here? I appreciate that question. So let me come back here. One thing I would recommend, there's a couple of things. One thing I would recommend that in my own experience has worked quite well is having the leadership of these companies, as well as the investors in these companies, try to walk in the shoes of the consumers for whom they're trying to create value. I used to run a series of methadone clinics in Maryland. They were headquartered in Baltimore City. We served an entirely Medicaid population. And as a pediatrician, as a clinician, I already work with predominantly Medicaid populations. However, as an operator, as a CEO of a company, I was multiple levels away from the patient population we were serving. We had a real issue in terms of compliance of the patient population coming to group therapy, and group therapy was one of the largest revenue drivers in our business. And so we tried to better understand why weren't people showing up. We tried to ask around, try to understand from our staff. No one really had a good sense of it. And we did hear that there was apparently an issue with housing and folks that were homeless, and that might be somehow contributing to not being able to show up to group on time. And so what I ended up doing is I spent a day, a 24-hour period, being homeless. Now, obviously, like being homeless in a self-imposed design exercise is fundamentally different from a trauma perspective than actually being homeless. But it was very instructive. I spent half a day under a bridge in Baltimore City waiting in line for the homeless shelter, then getting onto this bus that shuttled us to some random place in East Baltimore City, and then staying in a place in this gutted motel with 100 other men, and sleeping in a bed without a cover, and there's no toilet paper, and the wind, it's freezing. I mean, there's so many learnings that came out of that. And in the morning, when I got up, what I learned is that my patients or clients, in order for them to get in line and actually have guaranteed shelter, especially in the cold months, they had to start getting in line by noon. So if we provided group sessions later than noon, if someone's going to choose, do they come get group sessions or do they get housing? They're of course going to choose housing. And so that ended up forcing us to rethink and redesign our scheduling, our processes. And so back to the question, how can these gaps be remedied that some of these data on this slide are identifying? We need to build empathy by walking in the shoes of our end users for whom we're designing, and human-centered design principles and tools and tactics are fantastic to build that empathy. Thank you guys for that question. So let me move on to the next slide here. All right, so we had our 4 categories of market failures. Of those 4, we'll start with care coordination. When we took the 84 companies we surveyed, we tried to identify candidate companies that seem to best represent some of the domains we were looking at. Now, I'm not vouching for any of these companies per se, although I am an investor in several of them. But some of these companies are really interesting. They fall under this domain of care coordination, but they aren't exclusively focused on care coordination. And I'll give you a specific example. So as a grain of salt, I am an investor in this company. It's a company called Inquisit Health. And what they are is a network of peers. The peers connect with the consumer through multiple modalities that Inquisit Health facilitates through its platform: text, phone, video calls. And what's really interesting is that the engagement problem that is so pervasive, as well as the care coordination problem that is so pervasive, especially amongst duals, there's now data to show that the Inquisit Health platform, by empowering peers, can pretty meaningfully improve care coordination as well as engagement. And I put here a link to a study that was recently published, and kudos to Inquisit Health. So they're one of the companies that actually are investing in the research to validate if what they're hypothesizing to do is actually working. As it turns out, they have a pretty impressive effect size there. Next set of candidate companies is in the domain of data collection and sharing. And of those companies, I'd like to highlight FigMD. I'm not an investor in this company, although it's a great one. I would happily invest in it. And what FigMD does is essentially aggregate large data sets of claims and other types of data, and then pull them together for multiple purposes. They use them for things like informing payers of how to tier their networks, of informing providers how to go into risk-based arrangement with payers. And also, they're being used by some of my colleagues at the American Board of Family Medicine, and the link is provided down below, to do really fascinating social deprivation indices. And more information is there in that link, but really exciting use of big data, especially to address needs for duals. The third of the four market failures is in the home and community-based services space. So things like home care, home health, home delivered meals. And there's several candidate companies here. One of the ones that I'm quite excited about is a company called Wellbe. This is a technology-enabled PACE program. I'm not an investor in this one. And the thing that gets me excited about Wellbe is that they're building on a trend that is highlighted by the link I provide in the source below, by the National PACE Association, which is an effort called PACE 2.0. And that is an undertaking that is attempting to more than double the number of enrollees into PACE programs. PACE programs are programs for all-inclusive care for the elderly, and essentially tied together payment and provision of services into a fully risk-bearing model. Really interesting approach to align payment and outcomes. And finally, the fourth set of market failures is in the enrollment and engagement space. And some of the companies trying to address those market failures are the ones that are listed here. Among those companies, Uno is a really interesting candidate technology. I'm an investor there. And what they're doing is increasing enrollment of high-risk Medicare beneficiaries into social supports. And by doing so, creating financial value for Medicare Advantage plans. More importantly, they're helping beneficiaries get services that otherwise they don't realize that they're actually eligible for. And so with that, we are down to, I believe, the last minute. I appreciate you all listening. I hope this has been helpful. And if there are any last minute questions, feel free to throw them in the chat. Otherwise, I think we can wrap up and hope everyone has a great rest of your week and weekend. Josh, any questions from you?
Yeah, well, I actually had a question myself that I was keen to ask a little bit about hearing that presentation, and there was actually a question that's come through just as I asked mine, but let's go with the one I had in mind. I was keen to just understand a little bit more, and I think the audience would be about what Social Innovation Ventures does. I imagine from what I heard in that presentation and what you talked about there of how you did that. That process of going and living as a homeless person for a short period, and so just to have that experience, that you might have a bit of a special ethos, I suppose, in terms of your investment. So maybe you could tell us a little bit about what Social Innovation Ventures does and stands for, and how you invest.
Yeah, you bet. So Social Innovation Ventures is an investment fund It's mine and my wife's capital. We invest as angel investors. We try to do about 10 deals per year. Usually our check sizes are anywhere from $10,000 to $50,000. We're fortunate to be able to have invested already in about, I think we're at 17 companies now. The businesses we invest in and our investment thesis is really squarely focused around health equity. And so our bet that we're placing is that while in businesses serving, let's say, Medicaid or duals populations, the unit economics per capita aren't particularly compelling, but when you look at the volume, especially of Medicaid beneficiaries, the total addressable market becomes enormous. And my hope, and it looks like we have some early process measures suggesting this will be the case, is that by investing in these types of businesses and these types of entrepreneurs, we can hit or beat consensus and get internal rates of return that are comparable or better than general investors in the healthcare space, and hopefully get the institutional investors involved in investing in the space. And then we have more innovation and fewer market failures.
Fantastic. Yeah, well, hopefully some people listening can sort of follow up on that. We do have one last question. I was going to say as well that if you did want some of the slides and some of the research, there is a report out, as Andre mentioned on this, that I guess takes a bit more of a deep dive rather than the sort of curtailed version that we've been able to get through today. But I guess, yeah, just to round us off with the last question that came in here, are there any particular or which subsectors of technology do you think have the most potential to benefit Jules?
You bet. So one of the categories that in the methods I highlighted here, let's see, it's on slide, here we go. Under technology type, there's a section of technology-enabled services. I'm very bullish on businesses that are displacing boring, traditional brick and mortar service businesses, but doing it from the ground up with technology. I alluded to Wellbe. That's one great example. One of my investments, a company called CityBlock, which is also on the list. Businesses that are either doing tech-enabled primary care, technology-enabled insurance, technology-enabled home-delivered meals, housing. I mean, that is a space that I think there are proven revenue models, and there are enormous inefficiencies. And by taking a proven revenue model, layering a touch of or a lot of technology on top of it, and then removing those inefficiencies, I believe that incumbents will be outcompeted. And by virtue of using the technology, we'll have a much accelerated path towards value-based payment. And so I think it's a nice way not to be overly disruptive, but set up a gentle but consistent momentum towards disruption by utilizing existing revenue models.
Fantastic. Well, I really appreciate you joining us, Andre, and I guess rounding off our day of content today in the Biotech Leaders agenda anyway. If you do have any sort of follow-up questions, or indeed to sort of find out more on the report, or indeed the slides, then please do get in touch with Andre, or indeed with myself, and I can help facilitate that. That's it for the Biotech Leaders agenda anyway. There is a final session on our Health Tech Leaders track from the SVP and Chief Digital Officer of Anthem, Rajiv Ronkani, in 30 minutes time in the Health Tech track. But I just want to say a huge thank you to Andre, huge thank you to all of our speakers who have joined us, 200 plus of those over the last week or so. All of our partners and sponsors for making the event possible across all the different sort of formats that we've been running this week. The event is by no means over though. All of the sessions are now available on demand, so you can watch anything that you missed over the last 3 days of content. And the partnering platform and one-to-one system is open tomorrow and then throughout next week. So please do keep on with those meeting requests. If you do have more comments or questions from any of the sessions that we've had over the last 3 days, please keep the conversations going in there. And yeah, any questions for any of my team, then please do get in touch with us. And yeah, hopefully next year we may be in a position where we'll be able to bring together people as we normally like to do in the physical world. But this is it for me, I suppose, on the LSX World Congress 2021. Thanks for making it. What I hope has been a great virtual experience for everyone, and hopefully see you all in person before too long. Thanks.